the larynx, the beginning of your lower respiratory tract. A lot of really neat features going on here. One major feature that everyone seems to recognize is this thyroid cartilage. Another way to call it is the Adam's apple. Reason why it's called the thyroid cartilage is, well, because of this gorgeous beast right here. This gland called the thyroid gland. Other neat features about the larynx is you do have something called an epiglottis that looks like a little leaf attached to a leaf stem. What's so great about it is, well, if you take a look-see at the side, you got your esophagus right here. What stops food from accidentally sneaking into your respiratory tract? You don't want food in there. Well, it's that epiglottis. When you swallow, what happens is that epiglottis sort of just folds over and makes certain and lets food pass over it. Underneath that epiglottis and to the beginning of the opening of your larynx are your vocal cords, which are attached to a arytenoid cartilage which we'll just probe and discover a little bit more. But let's point out really quick to help make certain that we know the layout of the map is this guy right here. Just below that thyroid cartilage, you also have the cricoid cartilage. Now that we are familiar, there's your epiglottis, there's the thyroid cartilage, there's the cricoid cartilage, there's the arytenoid cartilages. Let's go ahead and sneak over to a superior view of that. That way we can visualize those vocal ligaments just a little bit better. You'll notice that the vocal ligaments, these guys right here attached to this thyroid cartilage, with the arytenoid cartilages being placed just above this cricoid cartilage, which I'm going to mark here with a circle. Again, these vocal cords or folds or cords are attached to that thyroid cartilage, but the one that really makes it move and makes you sing in higher lower pitches are the arytenoid cartilages and how they are positioned. That's them right there. There's the vocal ligaments. Again, the arytenoid cartilage and the thyroid cartilage attached to them. Let's go ahead and superimpose our fleshy goodness. There's ourselves the glottis and epiglottis. You'll notice that when we open these muscles right here, pull them up nice and wide, these cricoarytenoid muscles, you get a really deeper tone. You get a deeper bass, like Barry Manilow bass. Oh yeah. But if you pull them nice and tight and really close to each other, you get a really high pitch. Nice and wonderful. So the more wide the opening is, the higher the lower the pitch goes, which explains why men have a deeper voice as they go through puberty, because really that testosterone is making that larynx, this opening, just a wee bit wider. We're going to skip that one. I would highly suggest, if you are interested in seeing how all of the things of the upper respiratory tract plus the lower respiratory tract work and go, watch this video. Because this isn't my video, I'm not going to play it. That would be a copyright issue, but please go and watch it. But let's go ahead and continue on. So we got ourselves a cross section. We're still looking at a superior view. We have gone and descended down into the trachea, though. We are no longer looking at the larynx. We are looking at the trachea. You'll notice hopefully first and foremost, is that this tracheal cartilage, it looks like a C. There's the esophagus. Why do you suppose you got this C going on? Well, I'll tell you. What's going on is you need to have this esophagus pliable and open wide. But you also need this structure so you don't have your respiratory tract closing up. You don't want that going on. You kind of want to live, but you also want to eat, so you compromise. You kind of cut out that portion of that cartilage so that this esophagus can expand. You'll notice that this trachea is nice and wide, but You're still inhaling dust particles, you're still inhaling smoke particles, especially if you're a mouth breather like me. So how do you get that junk out of there? Well, you can cough, but coughing needs some help. So within this lining of your trachea, you have pseudostratified columnar epithelium that are ciliated. Cilia help move things out or along. You'll also notice you have goblet cells. Goblet cells like to pour out their contents like goblets do. Of goblets of wine, goblets of whatever you have. These goblets love to pour out what they have contained inside of them. In this case, it's mucus. So it pours out that mucus catches it, and these cilia carry that mucus on out, and you cough it out, or it just slowly secretes it out into your esophageal region and you swallow it. Or maybe you cough it out, who knows. Let's go ahead and continue descending. We just talked about the larynx. We talked about, here's the trachea. We talked about the trachea. We got those C cartilage. You'll also notice that's a little bit more of has elastic tissue to it to help keep it pliable and rebound back. At the end of the trachea, where the trachea begin and the bronchi end, is this division. I hope to see it a little bit clearer. Let's see if we can't find a better picture real quick. There we are. So here's a nice magnified view. You got the larynx, trachea, and if we continue descending on down, we'll notice that it divides off into a pair of bronchi. The dividing point is called the carina. K-A-R-I-N-A. Carina. Now, let's say that you do have something careening down into your trachea. You accidentally inhaled a pee. The most likely direction that this pee is going to go kind of relates to the size of the lungs. The right side, the right bronchi, is most likely going to receive that pee, the PEA. Thought I needed to clarify that a little bit really quick. That PEA, the P, makes it on down because several reasons. One, this lung is larger, which means it requires more air to come into it. So this is now wider. The right bronchi is wider. It also has more of an angle shooting downward compared to that of the left lung. So it's most likely going to catch that P. So you got the major bronchi. You'll notice again about these that there's those cartilaginous pieces to it. You got the elastic tissues to it. You also have those columnar epithelial cells laced with cilia, along with the goblet cells. Something to note about these specialty cells, these goblet cells, these ciliated cells, all of them really are super important. If they're gone, then you got problems. When someone smokes, you are damaging those cells, and you can actually destroy those cilia so that they no longer are functioning appropriately. And that will result in a cougher's cough, smoker's cough. That's the one I'm looking for. Smoker's cough, which is a very unproductive cough. You really do need those cilia. From there, you got the trachea, you got the main bronchi, then you got lobar bronchi. Remind me again, I plumb forgot. What are those sections of lungs called? Ah yes, lobes. So these lobar bronchi are bisecting off or going off into these different lobes, which means most likely, and hopefully you've come to this conclusion, the right lung has 3 lobar bronchi just like it has 3 lobes. And the left lung has 2 lobar bronchi. Afterwards, you got the segmental bronchi, then you get the bronchioles and the terminal bronchioles. You'll notice as we descend down these tubes, we go from the trachea, the main bronchi, the lobar and segmental bronchi, that those cartilaginous tissues are starting to disappear. These airways are also getting much and much smaller. So that's left more and more to a different tissue to try and keep it open. The smooth muscle. Smooth muscle is found within especially the bronchioles and terminal bronchioles. These can be closed off and reopened depending on what you need. So if somebody's going through an anaphylactic shock or they're having some type of breathing issue, number one way to fix that is a quick shot of epinephrine, which causes this smooth muscle to dilate. Remember that epinephrine is a sympathetic nervous response. It's a fight or flight. And if you want to run away or fight really good, you better be getting air to the right places. So epinephrine stimulates those airways to open up wider to get even more air in with each breath. We have ended the conducting zone, that dead zone. And we're now reaching into the respiratory zone where you're actually starting to get an exchange of air. You got the respiratory bronchioles, the alveolar ducts, and finally the alveolar sacs. Let's sneak into those alveolar sacs and take a look-see at what they look like. Here's a dissection of that lung. You'll see there's your respiratory bronchiole. You got the alveolar duct and the alveolar sacs. Very airy. Within these, we'll come back to that in a different slideshow. Let's come to this really quick. Within these alveoli, you're going to find a variety of different cell types. First off, you got the type 1 alveolar cell. This is the cell that allows for respiration to occur. Type 1 is the one to let air exchange happen. Oxygen and carbon dioxide exchange. Type 2 produces something called a surfactant. It's a lubricant. It's a thing that what it really does, what it's really good at, is keeping those lungs, these alveoli, open. Without surfactant, the surface tension, we're going to say, the surface tension of what's in there is going to make it really sticky, and each time these alveoli collapse, it's going to be really, really hard to open back up. Finally, you do have one last cell, the alveolar macrophage, that's hanging out, just making certain that there aren't any microbes or viruses that actually made it to this point, but most of the time they don't. So those are the words that we've already discussed quite a bit in detail. Here is the layout of the tissue types. Let's actually go back to this little diagram really quick as a review. So first off, let's point out this. This is your nasal cavity. This is your right here is your oral cavity, sorry. You got the nasopharynx, you got the oropharynx, you got the laryngopharynx, which is the end of your respiratory tract, but it's still a part of your upper or your conducting airway. We move on down into that lower respiratory tract. So we got the larynx, trachea, there's the carina, there is the primary bronchi, the lobar bronchi, we got ourselves the segmental bronchi, finally ending up in the bronchioles. Moving on down from the bronchioles, we move into the more microscopic structures of the terminal bronchi, the respiratory bronchioles, alveolar ducts, and alveoli. Talk of tissue type really quick. Starting off up in the upper respiratory tract, anything that you're going to see any type of friction such as chewing or picking your nose or what have you, you're going to have a non-keratinized stratified squamous to try and keep that protection. The more layers, the better. But once you get past that larynx, where you're going to see the abrasions and all that stuff, you're going to move on down into this area where it needs to stay nice and open. So you're going to have a hyaline cartilage lacing it all the way down into your bronchioles. You're also going to have this elastic fibers all the way through to help keep that stuff pliable. But let's talk about the different tissue types here as well. We got the pseudostratified ciliated columnar, which you might remember help out move stuff out of your lungs and down into your esophagus or into your mouth to spit out. As you get further and further down into these tubes, these lumens get smaller and smaller. So the next one that comes along is actually the ciliated simple columnar. You're no longer pseudostratified all bundled up. You've become simple columnar to help maximize the amount of space for air to pass by. In that exact same amount of space and plus some, you got the goblet cells, which are producing that mucus to help trap that stuff to get it on out of here, up and out. You progress further down, you'll also notice that you'll have some basal cells. That's sort of just a way to help form a protection. You'll also notice that you have begun in this region to have yourself some smooth muscle. Club cells are also there. They're the replacement for the goblet cells as you get further down. You get further down, you get into the non-ciliated, simple cuboidal. Notice that these cells are getting smaller and smaller and smaller until you finally get into the simple squamous, which is the one that allows actual breathing. This is like the type 1 alveolar tissue. With that, that is the end of this discussion. Remember, you got this.